Good afternoon, everyone, and welcome to our second last in this series of webinars looking at adaptive practices to COVID in the drug and alcohol sector. So I'm Nadines from the National Centre for Clinical Research in Emerging Drugs in St Vincent's Hospital in Sydney. And this series is also co-hosted by the National Drug and Alcohol Research Centre, who's one of our consortium partners with NCRED as well. Before we start, I would like to pay my respects to the Gadigal people of the Eora Nation as the traditional owners of the land on which I'm seated, and pay respects to elders past, present and emerging, and acknowledge that sovereignty was never ceded. Today, I'm really pleased and fortunate to be sitting here with Nicky Barth. Not here, we're in separate computer zones, but with me today is Nicky Barth, who's the director of the CEO of the National LGBTI Health Alliance. And we're talking about queer communities and what we're doing in the space of drug and alcohol use and responding to any problems emerging from it. So Nicky's been with the Alliance for almost 2 years now as the executive director. And came with a background with New South Wales Ministry of Health, ACON, and NUA, the New South Wales Users and AIDS Association, as well as experience in the UK. Nicky, I'll hand over to you and let you introduce yourself a little bit before we get going.
Thank you, and hello everyone. I have to say this is my first webinar, which is quite amazing really, and it's a very strange feeling, sort of not being able to see you all. But I don't know what else to add to that, to be honest, Nadine. I've worked in drug and alcohol, particularly bloodborne viruses, for many years, and worked in a harm reduction, part of the National Health Service in a harm reduction service in the UK. So I think I'm probably coming up to about 29 years, which gives away my age, as I always say. But I've always just been very focused, I suppose, on harm reduction and in particular bloodborne viruses, particularly when I came to Australia, because harm reduction is so bloodborne virus focused. But of course, also interested in drug treatment, and very much have always been interested in drug use amongst LGBTI populations.
So I guess from my perspective, I'm kind of interested to know what the Alliance is doing in the drug user and drug treatment space.
Well, interestingly, and maybe I'll just say a bit about who the Alliance is actually for anybody who's not familiar with us, if that's okay.
Yeah.
So we're the national peak for LGBTI health organisations across the country. We also have sort of corporate and not-for-profit, non-LGBTI health organisations that provide health programs as members as well as individuals. We really are primarily focused in mental health, suicide prevention, ageing and aged care, disability, and we're just moving into palliative care. At the national level, there hasn't ever really been investment in drug and alcohol. It's really been remiss, I think, other than the Commonwealth funding through the NGO treatment grants. So much of our work is on the peripheral in many ways. We run Q Life, which is the teleweb and phone chat service that runs every day from 3 till midnight. Many of the people who call and reach out to that service wanting to talk about their drug and alcohol use and the underlying factors for that. As we know, many people in our communities use illicit drugs and at higher rates than the broader community. And for many people, that drug use is fine, and it's about pleasure, and people, practice harm reduction, within the way that they're using. But for some people, people do get into a bit of trouble and are more looking for services and support. So our role at the moment with regards to drug and alcohol, we're trying to raise the profile of the use of drugs amongst LGBTI people with the Commonwealth. And that's an exciting journey to be on, and an interesting one, given that we're a priority population in the national strategy, that we're in the position of having to do this, because, as I say, there's not much of a national lens, and we really need to have that in this space.
So what kind of things have you or your members been seeing during this COVID period, and as we emerge from it, we heard last week from Garrett Prestige with the Flux cohort of gay and bisexual men that many of those men, their drug use was very much associated with their sexual practice, and for many of those men that had both had dropped off a lot, so they saw marked decreases in use of drugs like GHB or methamphetamine. But we're seeing different things in different cohorts and different groups of people. So people with problematic use or that might be using daily or dependently, we're not getting any sense that that actually slowed down during the lockdown period. That some concern about supply disruption that didn't emerge in the first 3 months, but now anecdotally is emerging. So clinically, we're hearing people are finding it harder to buy their drug of choice, and the price has gone up. And certainly some of the survey data is starting to support the increase in prices at least. So that brings with it a whole range of other concerns around withdrawal or decreased tolerance, and then maybe overdose risk if people are starting to use again in the dependent end of the spectrum. But that's a kind of LGBTI lens free analysis of what's going on. So I wonder if you can kind of put the queer lens over the top of that and explain a little bit more about what you think's been happening during COVID and what we need to be looking out for as we go forward.
Yeah, I think it's been a really interesting time. I mean, I can remember at the beginning of COVID being really concerned about the potential, particularly with regards to alcohol. I was more concerned about alcohol and illicit drugs, but I was really concerned that we would start to see a really dramatic increase in, particularly, as I say, with alcohol use. And I think when we're having this discussion, it's important to remember that we have, across the queer communities, the LGBTI communities, we do see high rates of alcohol and other drug use in comparison to the broader community. So for any increase for us is particularly worrying, it's worrying for anyone, but we're already starting at that higher kind of benchmark. And I was concerned to the point of talking with ACON and Thorn Harbour about needing to put a brief together for the Commonwealth as to whether or not we needed to do a campaign. And what we're seeing that's coming out at the moment from some of the research, like with the Flux study, with the COVID surveys that have been undertaken, we're seeing a reduction in the use of illicit drugs. And with the COVID-19 Flux survey, we're seeing a slight increase potentially in alcohol use amongst that cohort of gay and bisexual men. Both Thorn Harbour and ACON, who are the main providers of drug and alcohol services from community-controlled organisations and are members of the Alliance, what they're seeing is the same, that particularly people are seeing this as an opportunity to change their relationship with illicit drugs and with alcohol. And Thorn Harbour had seen an increase in the demand on their services since they've gone online. So I'm not sure they're not sure whether that's due to availability online and that being more open for people to have access, or whether that's needs driven. With QLife, we haven't, I had a look at the data and we haven't seen any significant increase in the demand around people needing to come onto QLife to talk about their drug and alcohol use. But we did have access to some market research that from Newgate, and what that was showing, and so that was broad population surveys, market research surveys that did have, it wasn't a great LGBTI indicator, but they did have that. And what that was showing as of the 25th of June, that in the past week, 21% of people who identified within that LGBTI indicator had stated drinking more alcohol than usual that past week than the general population, which was at 14%. So I think we need to be thinking about what all of this means when we come out of this, or as we start to come out of COVID-19. And Simon Ruth from Thorn Harbour, in his feedback to me, raised this issue of, increased daily ongoing alcohol use, for example, and the development of dependence, and, people not recognising that necessarily, but that maybe those patterns of use will change. when we went into COVID, I was worried about people using GHB, for example, at home on their own. You know, we were asking people, well, not asking, people, we have been asking people to be using in particular ways, particularly with drugs like GHB, don't use alone, all of those things. And then COVID put this sort of umbrella of different kinds of demands and risk potentials around people using at home on their own. So I think that there's, you know, there's a lot of stuff going on within COVID that we have to think about, and now we need to be thinking about how we get out of that and the needs of people moving forward.
Yeah, I mean, we had a very interesting webinar with Jack Freestone from ACON a couple of weeks ago about overdose avoidance coming out of, with GHB coming out of COVID-19 social distancing measures, because that we all have this kind of pent up sense of ready to get back out there. And we're certainly seeing in the hospital here, the kind of alcohol related presentations to ED background kind of New Year's Day kind of levels. So we are getting this sense of people getting let out and going for it, if you like. We were talking about ways to reduce overdose risk with GHB, with that concern, pretty much focusing on queer communities, but we know that GHB is being used across broad spectrums of the society.
Just on that, Nadine, I think you know, social spaces are important to everyone, particularly important to LGBTI communities, where, you know, clubs and like the nighttime bars have always been really important spaces for us to go. And so I think the impact from COVID around isolation has been really significant, and other data is showing that that's the case. I appreciate everyone has been isolated, but I think there are particular needs from our communities with regards to the impact of that isolation. And so, yes, I think, you know, once those, you know, those restrictions start to give, we'll see people wanting to party, and people won't necessarily have the tolerance that they have been used to.
Yeah, and perhaps a loss of that kind of social skills that we had before COVID-19, and more anxiety around getting back into social connections, and the place that drugs and alcohol play in managing our kind of social anxieties. So thinking through all that in advance, I guess, is one of the things that many agencies are kind of suggesting that we go forward. I just want to remind people that there is the Q&A function. Please send in any questions that you like. Please don't say I don't sound well. I am well. I've just got something caught in my throat. But thank you for your concern.
That's great.
But thank you. Yep. So please, any questions you've got, please put them on there. So in terms of the services that you work with, or that part of the Alliance, how have they changed their approaches to reaching out to community during this COVID time? And is there a sense that some of those changes might actually be carried forward as new changes and welcome changes to the way that services are provided?
Yes, so services have moved online, and I think, you know, the feedback that I had from Jack at ACON was very much that, you know, they were kind of abrupt and had to happen quite quickly, and people have really taken, I think, to the online opportunities of engaging. They've noticed that they've got a reduction in people not showing up for appointments with the service being provided online. And I think that's you know, that obviously that's really important. And I think also, you know, the LGBTI communities, we're really used to engaging online, particularly gay men. And so I think being able to access that online services has been really important, because it's also that other layer of anonymity, I think, confidentiality, safety, that safe space. So, and as I said, for Thorn Harbour, with them moving their counselling services online, they've definitely seen an increase in demand. And it's, as I said then, it's hard to know if that's due to an increase in drug and alcohol issues, or if it's because the availability of an online service is a useful one. And so very much those services will be looking to, moving forward, have that mix of face-to-face and online, so that people can have that flexibility in how they access that service.
Yeah, so I've got a great question from one of our listeners, observers, watchers, saying that what are the limitations to online consultations over face-to-face? Or do you think that online is the new normal, particularly in the LGBTI communities?
Look, I can't speak from a practitioner perspective around, having that understanding of like a counselling session with somebody in person versus online. I think there's benefits and costs to kind of each model. That notion of actually sitting with somebody physically and feeling held when you're talking about what's going on for you is a really important dynamic, as we know, in counselling. Oh, I'm sorry about that. But the other side of that is when we're looking at the vastness and the geography of the country, the option to be able to connect in this way means that people who wouldn't been able to access these services can. And I wonder about, over time, what else we're going to be able to do as we learn about developing and delivering these models online, what it is that we can do to make them more effective, and evaluating them to understand really understand the limitations over, the limitations over face-to-face versus online. I think it's a really interesting space. I think there's costs and benefits depending on what you're wanting and where you're living, but definitely it's people have been adapting, and I think from the response at ACON saying that people are coming more often and are not attending less frequently is an important outcome.
Are you concerned, though, that there might be some perverse incentive in the system to fund cheaper to deliver online and telephone counselling over face-to-face, rather than seeing these new modalities as being an extension or an additional service? Is that a concern for you, particularly for LGBTI communities?
Look, I mean, governments are always looking to save money, and this could well be seen to be one of them. But I don't think that anybody's saying that online support would become the new normal. It's about being able to offer both. So those people who want to have face-to-face would be able to access that in a safe way as the restrictions are lifting. And as you say, Nadine, the online support being much more of an extension of, or for those people who physically can't access. I mean, there are also, lots of issues for people with disability around accessing services. And at the end of the day, you still need to pay the counsellor who's providing that service. You still need to pay for the infrastructure for that service to be provided, the supervision to that counsellor, etc. And so I think it's that it's not necessarily cheaper, because that person who's providing the service also has to be sitting somewhere that's funded. But I think for us, with providing services to vulnerable groups and hard to reach populations, having that tool bag of various ways to do that so we get greater reach for people who are harder to reach is really brilliant. We just need to make sure that's continues to be done to a high quality, and that we evaluate to see what people's experiences are. I mean, sorry.
Oh, so we've got another question, and this is actually a question that we've been exploring throughout this whole series. It's about, do drug and alcohol clinical staff need additional training to run consultations online or by telephone? We've addressed some of the kind of micro skills that might be needed. We're actually putting together an online set of e-learning modules on the micro skills that telephone counsellors can use. But from your perspective, particularly for LGBTI communities, are there additional training needs that we could be meeting at the moment?
I mean, I'd be interested to see what additional training people feel that they need to move their practice sort of online or on the phone. I mean, I know just anecdotally that there's been some significant changes in the delivery of drug treatment through like OTP and that in light of COVID, and all of this is really great. I think some of the changes that we've seen in the delivery of healthcare through COVID would have taken us years to be able to have achieved if it hadn't have been for a pandemic, when you look at the use of telehealth, etc. So, I mean, I think it is a different kind of engagement. I think what's important around working online or face-to-face is that people are trying to be able to engage really well with LGBTI people and have had good cultural sensitivity training around those specific needs that we have and the differences in the issues that get presented from our communities and with the broader community. I mean, at the end of the day, those core communication skills that people will be using in their day-to-day work face-to-face can be transferred, and you know, that how you develop empathy and connection, I think, is still possible, particularly if you've got an existing relationship. I think it takes longer. I think if you were seeing somebody for a brief intervention over a shorter period of time, I think that's the interesting thing for us to evaluate around what that experience has been like versus when you see, you know, you meet somebody that you don't know to start to have that relationship. But that, you know, there's a lot of alcohol and other drug staff out there, many who are really, really equipped, and some of the tools that you were just talking about there, Nadine, to enhance that, of course, will be useful. But at the heart of it always is ensuring that people are, even those people who think that they're really great at working with LGBTI people, get some training so that those connections can be even more meaningful.
Okay. I've got two questions here about online kind of work. I'll just move to Liv from way out Wodonga, who says that she agrees with your point about social spaces being restricted. And have you got any data on the success or reach of online social gatherings and whether they're having a positive impact on LGBTIQA+ communities?
Look, I don't have data, but I know that there have been significant online gatherings across the community. I was part of the Equality Australia online gathering that they had, the Queer Lovin', it was a few weeks ago, it could have been longer than that. And there were several hundred people participating in that, coming in and out to those spaces. I think they're interesting spaces. I know that DJs have been doing sets that people could then join in, and you know, when that all first started, I was thinking, oh my God, this is going to be really interesting, where we've got people with DJs in their homes and they're going to be drinking and using on their own, and where is all of this going? But you know, at the end of the day, we do also know that LGBTI people are quite well educated around alcohol and other drugs, and are used to practicing harm reduction, even though there are still a number of issues around that. So I don't know about the data, but I do know that they're happening, and people have been really grateful for them, and they've been an important way for people to connect and remain socialised, because that's such an important part of many people's lives.
Yeah, yeah. And what other online services are available? Are there any groups that are available online in the LGBTI A&D sector? This is a question that's been posed, and I just to preface that is that I know that here we've really struggled to find groups that previously were specifically there for queer community not continuing during the online time. So there seemed to be a bit of a gap in service provision. Are you aware of any online groups that are running?
So are you saying, Nadine, that face-to-face groups stopped and didn't go online, so they just stopped?
The ones that we, in this area, so I'm doing inner Sydney,
yeah.
The ones that we had been familiar with at our service anyway were not continued. Yeah.
So look, what I can do after this is I can put a call out across our membership and get a list of online groups that I can send to you that maybe you can then add to send out, because I can't tell you of them offhand. But what I do know is that community groups have been forming online groups. I know that Dykes on Bikes in Victoria, for example, have started a group online through Facebook.
I'm talking about specifically for drug and alcohol treatment, so like Smart Recovery or one
of
those.
I'm sorry.
So we've moved from social groups to maintain social
yeah.
And then specifically for drug and alcohol treatment groups, so whether they're 12-step or not, but some kind of group therapy or peer supporting therapy.
So no, so I mean the Dykes on Bikes group is to support people to manage their alcohol use. It's not a social group in that sense. It's a peer support. It's a peer support group.
Yep.
And that's what I will find out about, is those sort of peer-based support groups that have popped up online. With regards to things like Smart Recovery, I'm not aware of that at all, about those services going online, moving to being online, and it's a significant deficit if that hasn't happened, because I know that Smart Recovery has been quite popular amongst LGBTI people, and so that's something for us to explore. I can certainly go away from here and contact Smart and have conversations with them about that.
Great. And I think that would be great. So we'll put those links you sent to us on this website.
Yes, for sure.
It is sometimes difficult for people to negotiate this space if they're not directly connected with the two major services that you just mentioned that are based in Sydney and Melbourne, so Thorn Harbour and in Melbourne and in Sydney. So just in the last few minutes, I just wondered if you could talk a little bit about your harm reduction messaging and what you think works and what doesn't work quite so well.
I think for LGBTI communities, harm reduction information just needs to be very realistic and genuine and kind of honest. And I think that's been the success of harm reduction messaging. And I think, you know, HIV, what came out of HIV is that ability, particularly for gay men, to be able to do much more honest-based kind of education campaigns targeted at those specific drugs that are more highly used within the community. So I know that through people's websites, certainly when I was at ACON developing Pivot Point, what was really important there are personal stories, people sharing their experiences, factual information, allowing people to make informed choices. There's a brief audit survey on Pivot Point, for example, where people can go on and assess their drug use. But I think that the main messaging is around harm reduction, is that messaging is peer-based, it comes with lived experience, and that's been I think the bedding, the sort of foundation of the way that harm reduction information has been disseminated amongst LGBTI populations. And that's why it's been so successful for those it reaches.
Do you think we're getting better collectively at expanding the diversity of voices within queer messaging that's not just being dominated, for example, by gay men's needs? Is that something that's changing, that we're seeing a sort of more textured messaging, or you think there's still some work for us to be doing collectively in that space?
I definitely think that's a place where we need to be doing some more work. Absolutely. I think, you know, we're not seeing any shifts in the rates of alcohol use amongst LBQ women. We're not seeing shifts in smoking rates. And I think, you know, I think that's an important point that you've raised there, Nadine, around the focus really on much of that messaging in the past, particularly. So I think we are seeing some of that change with some of the community-controlled LGBTI health organisations doing more generic campaigns. There's, you know, I mean, I'm really know what's going on much more, I suppose, in New South Wales, having been at ACON, but there's been the campaign work done around smoking there. They've got some alcohol work going on at the moment for LBQ women and trans and gender diverse people. But yeah, it's definitely something that we need to be doing as we move into the future. And it's urgent. I mean, this the reality is that this hasn't been cutting through to larger groups of people across the LGBTI communities. It has been quite focused, recognising that also there has been some generic messaging that has gone out, particularly around things like GHB.
So does this circle back to where we started, which, I mean, ACON was funded for AIDS prevention and HIV, reducing HIV transmission rates. So a lot of the work was then very, very much necessarily targeted at the target population for that. So this sort of, does it circle back to your initial point that we need a national strategy that addresses queer communities around the country and substance use in those communities that's not necessarily tied to an endpoint like a specific disease transmission?
Oh, for sure. And yeah, absolutely. I think it is about moving away from that bloodborne virus harm reduction lens to a broader harm reduction lens that looks at all of the health aspects and impacts from using illicit drugs, which is certainly what I was used to in the UK before I came here. I was really surprised that Australia is so bloodborne virus focused. But I think that's also because of routes of transmission. You know, we've got much more smoking in the UK as a transmission route of both heroin and crack cocaine. So yeah, there definitely needs to be a more holistic harm reduction approach for people who are using illicit drugs and also alcohol.
Great, thank you. That circles us back to the start, and I want to thank you very much for your time. It's been really a fascinating conversation. Thank you.
Thanks so much for having me.
Okay, bye.
See ya.
Yeah.